While we're loading the talk, I want to introduce myself and certainly thank Dr. Abdulaziz, Dr. El-Kaidi, and Dr. Fayed for a wonderful presentation. You should be very proud of what I would say is a very thriving organization. And I would, on behalf of the American Orthopedic Association for Sports Medicine and our associated journals with Dr. Ryder, I would challenge all the young members of your association to sort of build on the foundation that these leaders have given you. And I think it's your opportunity to take the skills you have for the benefit of your patients to the next level. And so I would congratulate all of you. Over the course of 10 years, you've built a fabulous organization with great strength and depth. So
thank you very much. It can be nothing without your contributions and the guests and the attendees and our young fellows. Thank you very much.
Well, I would tell you, just certainly the venue, the organization is rock solid. You should be very complimented just at the operational aspects of the meeting, as well as the depth of the scientific content.
Thank you very much. Thank you.
So I'm from Chicago, Illinois, in the United States. And I'm going to speak a little bit. I think for many of the experienced surgeons here in the room, many of these techniques are very straightforward, but I'm just going to throw a little side twist on them for you, just to give thought for some of the younger surgeons. These are my conflicts, which really are unassociated with this presentation. You know, if I look strategically at what graft options are, the majority of the time we use autograft, but allografts are options that we use in the United States primarily with older patients. In my personal practice, and I'm primarily a sports medicine surgeon doing arthroscopic shoulder and arthroscopic knee. I don't do knee replacements in our system in Chicago. You're either a sports surgeon or a joint surgeon, but not both. And that's sort of how we do. I use primarily patella tendon for our competitive or high-risk athletes in either soft tissue grafts, such as a quad tendon or hamstring, in what we consider our recreational and fitness allografts. And I realize that certainly there's cultural implications, certainly in Asia and in the Far East, where the patella tendon autograft has unacceptable levels of morbidity. And I think I was speaking to one of our colleagues last night that I have one of each. And so I can tell you my patella tendon, albeit 25 years, a rock-solid knee, is still achy and difficulty to kneel on it. So I sense that in that sense, I guess want to introduce those who don't use that to go to the cons of using soft tissue grafts, such as first hamstring. The pros are it's really technically a very straightforward graft to harvest. I think there's virtually no anterior knee pain, and there's really no evidence of inferior outcomes associated with patella tendon in long-term studies. There is some clarity if you don't have a graft that's at least 8 millimeters in diameter, that you are at a greater risk for recurrent rupture and subsequent instability. The simple elements of the harvest are very straightforward and can be accomplished in less than 10 to 15 minutes. Small incisions. And the key element I'm pointing to here is for the novice who doesn't do many of these, ligating that band or adhesion between the semitendinosus and the medial head of the gastroc is the critical element. And if that's not properly released, this is what can happen. And unfortunately, this is one of my fourth-year residents who walked in. I was in another room, calls me and says, "Dr. Bush Joseph, now what do I do?" You can see that if that band is not released properly, that you'll see an area where the tendon stripper is diverted, and then essentially you get transection. I'm going to go through a videotape a little bit. I made bigger incisions. It's simple for those, certainly the younger surgeons in the room, but I think for the critical hallmarks. The size and location of the incision is not critical, but it's always more distal than what you think. And essentially getting a broad appearance, and I caution you to use a tourniquet when you're doing these procedures early on, and as you gain experience, then the tourniquet generally is not necessary. Identifying that superior border of the sartorial tendon where it folds up is the key element. And then as you make that opening incision, make sure that you don't damage the underlying superficial MCL. And once that's cleaned up and you can get underneath it, you're going to place your metronome sutures underneath that interval between the semitendinosus and the MCL. Now, the key element from here, many surgeons will look at and identify the tendons from the exterior. I'm a believer, I think it's better done from the interior. And when you pull the tendons out and we can identify them, usually it's pretty clear to see the rolled border of the sartorius, and then below that the semitendinosus and gracilis. And then I would like to go ahead and and free those up from there. I think my video may have frozen. If you could sort of restart that, if that's possible. Let's see. Once the tendons are identified, you're going to separate them out. Oh no, we're locking up here. All right, I think in the interest of time, I'll move forward. All right, we're separating the tendons out, and we're individually stripping the gracilis first. In this case, you can see I have a relatively thick tendon. We're going to essentially place crack out stitches into those, pull those out, make sure I've got good free motion individually. And here's the key element I really want to just highlight. In many patients, there's a solid thick tendon between the semitendinosus and that medial head of the gastroc, and it has to be ligated sharply. If you bluntly dissect that, I think that's where you run the risk of diverting the tendon and leaving it into a position where you can divert your stripper. I think it's locked again. Let's advance to the next slide. So, no, you're fine. Let's just go to the next slide. Yeah, I think that's the element. We could go to the advanced unit. Yeah. I think after completion, when the tendon is stripped, always make sure you let the tendon down, or let the tourniquet down. And if not, essentially, I think you run the risk of a hematoma, and very rarely, but a compartment syndrome can develop in the calf. I believe that drains should only be used with excessive bleeding, and generally that's rarely, if ever, indicated. And finally, make sure that if you have early hematoma formation in the first 3 to 5 days, you should consider evacuating this. If you wait until the wound dehisces, I think it becomes a much more difficult problem. The quad tendon, which I'll speak to now, initially in the United States was rarely, if ever, used. There was a paucity of surgeons who used this graft. It really was first described and popularized more in the early 1990s by John Fulkerson. And really, it's thicker than actually the patella tendon itself, so you have much more collagen. And so the advantages, it's a reliable large diameter graft. There's generally, in my experience, a very low morbidity, very similar clinical outcomes. The disadvantages is that you don't have that bone-to-bone healing that we do with the patella tendon. So this is a tape that was provided to me by John Zarachny. He's an excellent surgeon. And I'll show you, he has evolved this technique to the point where now this can be done to do a very small transverse incision. I suggest that when you initially start using this technique, that you should make a longer vertical incision and have a broader experience to it. But the key element is, again, it's a very thick tendon. You have to remove all that overlying soft tissue bursa. Now, there's a side-by-side, you can see. You have to be able to get down all that prepatellar and presartorial fascia tissue. It has to be removed. And then once you get down there, then you can visualize the size of the tendon itself. So I accelerate the tendon a little bit. And again, it's a very thick tendon that you can use. And I found, and I'll further explain, this tendon is what I'm using most commonly, actually in revision situations. You can pass an elevator up. You can, if you're comfortable, you can use your scope and place the scope inside to visualize. You don't want to drift into the vastus medialis muscle. That's probably the one technical aspect. So you can see, you can ensure that as long as you stay distal to that tendon attachment of the rectus femoris, which is generally anywhere from 8 to 10 centimeters proximal to the patella, it's a very, very safe graft. So I believe that in my experience, 7 centimeters is virtually attainable in virtually all patients. 6 centimeters is all that's necessary in pediatric patients. And I'll use this graft now to replace the majority of my hamstring patients, especially in adolescents and certainly in females. I think the agonistic effect of hamstrings on protecting the ACL graft in females, and you would take those hamstrings out, I think that's where we're seeing a higher risk of recurrent injury in this population group. So once the tendon is identified, and you make the longitudinal cut, whether with a double-edged blade or with just a single 15 blade, and then you can sort of dissect it off the proximal pole. Now, if you've got a male, you can certainly get away with a partial thickness tendon, probably anywhere from 5 to 7 millimeters thick. The tendon itself may be as much as 9 to 10 millimeters thick. And then once you sort of establish a plane, then it's a matter of just sort of passing up from there and then gaining control. Because the tendon is so thick at its attachment point, you do have to taper it down. And so once you taper it down a little bit, and you can gain control, and then you can place proper sutures inside. And I use this combination, and the vendors such as Arthrex and Smith & Nephew have wonderful kits and guides to help you with this type of situation. And again, these the commercially available cutting systems here to allow you to transect it through a very small incision. Once you have the graft, and then you can formulate it and use your, whether a sliding button or a closed loop button for your proximal distal fixation. So I think you ought to try this. It's worth doing in a cadaver model prior to doing that. Initially, when we were performing these, we were using a patella tendon bone block associated with the tendon, hoping to get that bone-to-bone healing. What we found, unfortunately, that the incidence of fracture is unacceptably high. And so this event, like what you see here, where you run that risk of a delayed fracture, delayed recognition fracture, has led most surgeons in the United States now to going tendon only and leaving the bone. When you're harvesting the bone, you have the proximal portion, which is the articular part of the patella, and I think the risk of fracture is much greater. Again, I would consider initial performing this procedure using a vertical incision at first until you gain comfort, and then you can advance to the smaller incision technique. Now, how do these patients do? Really systematic studies are quite comparable to what we see with the patella tendon, the stability, satisfaction range of motion, complication rates. More importantly, in my experience, and I think the majority of surgeons using the quadricep tendon, that the anterior knee pain and kneeling discomfort is significantly less. In a study comparing quadricep tendon to hamstrings, similar very strength recovery, similar sports and outcome scores, and really more importantly, there was no difference in isometric quadricep function strength. So we're not diminishing the hamstring strength, and we're able to recover with appropriate rehabilitation quadricep function. In terms of I think that the multiple studies would concur that recovery of quadricep strength without loss of hamstring strength is a critical element. You can see the thickness. So my current indications, I use revision, ACL reconstructions. I'm using quadricep tendon primarily. It's my primary graft of choice in PCL reconstructions, and it's my alternative graft in hamstring patients that I would previously use in hamstring, which is usually adolescent females. I hope that's helpful to you. Thank you.
Our second speaker will be talking this morning about more with respect to anterior cruciate reconstruction and talk about the indications for extra-articular augmentation. Dr. Aziz.
Thank you very much for the wonderful talk. I would like to share with you my experience with irritable band tendon. When I do it, this is actually not new. It started by Lumiere and McIntosh, and it was used as a standalone procedure to stop the anterolateral subluxation of the tibia on the femur. But soon drawbacks appeared, and because of the excessive constraint on the anterior rotation and failure to achieve anteroposterior instability and alteration in the kinematics and the progressive lateral laxity, as clearly mentioned by Werner Muller, and we'll come back to this point later. Because of the unsatisfactory outcome, it's not used alone anymore. We know that intra-articular reconstruction improves the results, but Still, there are some residual instability, as we clearly heard this morning, and the control on this anterolateral instability is not only the function of the ACL, but also some anterolateral structures. Some are sure, some are debatable, but any anterolateral structures anyway are very important in this aspect. And we know from the biomechanical studies that adding this stenodesis actually decreases the force in the ACL graft by about 43%, and it acts by load sharing. And this addition is better than ACL single bundle alone or double bundle alone. So it has something to add. And this beneficial effect actually lasted for quite a long time. This study was in 5 years ago, and the thing still holding. The effect on reduction of the internal rotation of the tibia on the femur as compared to interarticular alone was evident. So we come to the indications. Patients with high increased risk of failure or graft rupture are actually the indication. And there are several indications, and I'm not saying that every one of these is absolute indication, but if you put them together and consider several factors, then you might be able to judge when to do it. High demand sports, especially pivoting and cutting, and high grade laxity, grade 3 jerk, for example, and a revision situation, and young age at operation. We know that the younger the patient, the more the incidence of ACL rupture or failure is up to 25-30% in the teens, so it's quite a huge number. And loss of the median meniscus increases the force on the graft by 33 to 50%. This is a very important issue. We should preserve the meniscus for the stability and for the future of the knee as regards arthritis. And its loss actually added tremendous forces on the ACL graft. Generalized laxity, especially in female, needs a special graft, and it may need an extra-articular therapy as well. And the carbatum, which is part of the laxity, and allograft situations where incorporation, as we know, is less. This is an example of a grade 3 jerk where the knee locks before it relocates. This is grade 3 jerk. Other risk factors like increased tibial slope are increasingly recognized since years now, and a narrow intercondylar notch is an issue. And these are another added query indications. So, yeah, this has to be in mind when dealing with whether primary or revision ACL situation, where you need to add more control on the internal rotation of the tibia of the femur. The study group for the anterolateral ligament has come up with this decision tree, which is contains some of the previously mentioned indications. In the patient, it actually put into consideration the patient's history, clinical examination, imaging, and the patient profile. In the revision setting, or in the high grade, or when you see the evidence of anterolateral rupture, like a second fracture, and in a pivoting sport or hyperlax patient, the indication for anterolateral augmentation, whether by the brace or by the anterolateral ligament or inferior tendon, these should be put in consideration. Now, how I do it? Of course, a small incision does not mean big surgery. And your incision gets smaller and smaller as you get more experience. But as my professor, Allah yarhamu, Dr. Al-Farag said, no prizes for small incisions, but there might be prizes for good surgery, but no prizes for small incisions. I not normally draw the landmarks, but yeah, you draw it if you like, but just for demonstration. This is Gerdes tubercle. I'm not sure. Gerdes tubercle. Of course, Gerdes tubercle, lateral epicondyle, and the head of the fibula, and this is the iliotibial band, as you can see. And the incision is centered between the epicondyle and the head of the fibula. And you take as not much long length as it. The tissue is very flexible, and you can have a very mobile window of tissue, and you dissect them. Now, which part of the irritable band you would harvest? The irritable band is broad. The posterior fibers of the irritable band are the most isometric through the range 0 to 50 degrees of flexion. And this range is the range where pivoting and cutting is usually happening. So you need to take the fibers that will function best at this time. Also, the very posterior fibers end up with some bony, important bony attachment to the proximal and distal capillary fiber attachment. Together with the irritable band and the attachment to the cervical, they form an accessory ligament or extra augmentation to the lateral stability of the knee. So while harvesting, avoid the very posterior part of the irritable band to avoid the progressive lateral laxity as mentioned by Werner Müller more than 40 years or 35 years ago. So we need to a little bit anterior to the posterior margin and take the posterior 10 to 12 millimeters of the irritable band. And you do it the way you like. You put the clamp and then dissect up and down. And you need a length of about 10 centimeters from the cervical up to the end of the girdle. Now, we identify the lateral ligament and pass the graft deep to the lateral ligament. And we pass it because biomechanical studies has clearly shown, whether recent or old studies, that there's minimal graft length change when rooted deep to the lateral ligament when you attach it on the given femoral side attachment according to the biomechanical studies that allows minimal change of length. Also, passing the graft deep to the lateral ligament creates a pulley that will act as a check rail to stop anterior displacement of the tibia on the femur. This is the graft pass deep to the lateral ligament, and you can identify the lateral ligament by the landmarks drawn, or you put the knee in the figure of 4, you can palpate it. If you can't readily palpate it, straightly forward in the wound. And now, we come to the femoral attachment. The femoral attachment is critical. Actually, it has to be done right. The tibial attachment is fixed. It is the girdle tubercle, and what you need to actually do right is the femoral one. The study by Andrew Amos and his colleagues has shown that the posterior and superior to the epicondyle, this epicondyle, is nearly isometric, and the points above. There is minimal length change in the form of 4 to 8% of the length of the graft if you attach a graft to any of these points. And also, this together create a safe area for the attachment of the irritable band. So you have some degree of freedom between in this safe area. And with this safe area, you have minimal length changes when you pass the graft deep to the lateral ligament. We can clearly see the point here. This is the lateral epicondyle, and this is the posterior and superior point. And when we do the tunnel, pass the guide wire, we pass it proximally and anteriorly to avoid tunnel coalition with the ACL tunnel that you do, of course, concomitantly. And you put the guide wire before you pass the graft, because sometimes it's difficult to introduce the guide wire, or you introduce it in between the preparation suture, and you cannot advance the screw. So you put it first. And then, now we come to, we put gentle tension, and tensioning has to be in 30 degrees flexion and in neutral rotation to avoid the possible complications of overstraining the lateral compartment. And then you do your fixation. I would advise pulling hard to seat the graft in the tunnel, and then release your tension with the foot in the neutral position and 30 degrees of flexion. In this way, you get, you are not in the position of over-constraining the lateral compartment with the possible late sequelae of lateral compartment degeneration and the pain because of. Of course, if you tension it in the neutral position, there is possibly no increase in the pressure. As you know, it depends on the angle and the degree of tension you put. So if you do it right, there should be no problem. Also, there is another concern on the patellofemoral joint where you can cause lateral tilt and increase contact pressure if the leg is in external rotation while tightening the graft. Thank you very much. And I would actually urge you to use this procedure very precisely. I use it and use it right. If you don't use it right, it can be harmful. But you need it definitely in most of the settings. Thank you very much.
Thank you, Dr. Aziz. The next presentation will be Dr. Bush Joseph again to talk about timing of ACL surgery after the, when to do the surgery. Thank you.
Thank you again. That was an excellent presentation. I guess we'll get to the question and answer period because I'm curious to why you've gone to a tunnel as opposed to just merely lateral cortical fixation. So that'll be my question. I'll let you think about that. These are my disclosures, which are no different. So, you know, I think optimal outcomes in a diagnosis really optimal outcomes in treatment is really based on making an accurate diagnosis. And so really in understanding the patient factors like we talked about earlier this morning. I don't think any of us right now are at the point where we would consider performing an ACL repair on a high-risk competitive athlete. I think that, you know, we're sort of getting to that point where maybe we're going to try, but we think that we're going to try out with lower level, more fitness or purely recreational type people. So let's get to the essentially the decision point. Certainly, if this is a clinical question, we know we're dealing with more difficult situations, and so the initial workup is really what's most important here early on. Make sure that we feel comfortable to where this patient's going to go. Oh no, I'm locking up again. Gentlemen, I think I may need your AV help.
يا جماعة, individual.
I think I locked up again. So, I think I must have a mixed version of my outlook here. So, yeah, no, that's right. I kind of lost it. I'll go from the clicker then. There we go. All right. Just a click, yes. Maybe I have thumb deficiency. I apologize for that. So, nope, I think my thumb doesn't work, so. Okay, there we go. All right, so I think making that accurate diagnosis early on and getting the proper classification. Bob Schenck, who's chairman of the Department of Orthopedic Surgery, and did a fellowship with me back in 1988 in Cincinnati. I came up with a scheme that I think most of us use nowadays in terms of describing these various patients. You know, I don't think I have an Egyptian thumb. I think my Lebanese thumb is getting stuck in it. So I'm going to go to the. I'll go to the clicker. Let's do that.
حد يقف جنبه يا جماعة. حد يقف جنبه.
There we go. All right. So I think the most critical element that we're all taught early on. That's all right. I'll stay with the rollers right now. Yeah. Try it. All right. I think the most early thing I'd like to identify right on. Oh, where am I? Okay. All right. Let's back up one minute. Yes, I think it only works with Egyptian thumbs. Yeah. Okay. Let me back up a couple of slides. There we go. Okay. Back up. All right. I think what I do want us all to emphasize early on is that if you have nerve injury, I have a tendency to be more aggressive, and I'm not sure I'd be interested to see with the speakers in the room, especially those who are dealing with the motorbike accidents, which I can't believe 8 a day, and PCL and tibial plateau injuries. I don't know if you guys ever get out of the operating room at night. But my personal bias is that if there's a lateral-sided injury that has nerve injury, I tend to go into those early. I believe they're better addressed, and I think trying to identify and decompress a peroneal nerve and or perform repair or neurolysis if needed is better done early on when the tissue is easier to identify. So obviously if you have an anterior knee dislocation, you know, those are the ones have essentially a more concern over an arterial injury, and I think you're going to have a higher degree of scrutiny. In the United States, we used to do our arteriograms on all patients now, and we back down to those patients now only that have really significant clinical indicators, such as if they've got arterial brachial indices of below 0.9, those patients that were going to be more aggressive in imaging. Prior to these times when these patients are put to bed or splinted for a period of time, I think the most critical element for young surgeons and those who are triaging patients is making sure that the knee is properly reduced. If the patient is not reduced, then I think you're dealing with a much more difficult situation. There we go. And this is a situation none of us want to have. There's a patient, 65 years old, 14 days after presumed knee dislocation that was reduced, and you can see that the medial femoral condyle was still flexible through the medial fascia and really leading to a more difficult reconstruction situation. So I essentially, let's get to my light touches. I think that's the thing. It's a light touch, not a hard touch. So Americans work hard on everything. So there's really no randomized controlled studies in this area. And so really the decision points you have to come up with is when to really operate. And in my experience, in older patients, I've treated many of these patients non-operatively with really reasonable success rates. And I would consider that. The surgical morbidity associated with a large procedure on a patient of really older age group, I think caution is sometimes a better approach. And certainly the most controversial elements, in my opinion, is really getting back the patient to have muscle activation prior to a surgical intervention. And whether they have an external fixator on or we can just properly splint these patients, I think having muscle activation is the critical element, in my experience, to avoiding the development of arthrofibrosis. And an unstable knee is a much better situation than an arthrofibrotic knee that is stuck with a severe contracture. So I would caution you to stay away from that. So again, early surgery within 3 weeks is appropriate in these patients if you're deciding that have multi-ligaments that you're going to attack. Now let's get down to the simple, straightforward ones. Isolated ACL reconstructions, in our experience, we're trying to operate on within that first 2 to 6 weeks. The time is not as important, but more the critical elements of restored quadricep function, minimal to no limp, and really having reasonable patellar mobilization. If they've got a locked bucket handle tear, we have a tendency to be much more aggressive, and those are the patients we will operate on within a matter of days. I think immediate postoperative motion in these patients, because they do have a much higher degree of having symptomatic flexion contraction. If I have an ACL tear with a non-displaced meniscus tear, again, I think those go back to almost an elective isolated ACL, anywhere from 2 to 4, if not 6 weeks. But key to me is having an adequate range of motion and, again, adequate function. And then finally, the patient with a proximal MCL tear, I think these are the patients that I have the greatest problem with. In this instance, I've had patients that have the greatest degree of flexion contracture and be much more similar. Now, again, these patients, you have to fully assess the function of the deep MCL in terms of your actual timing. And so here's an example of a patient with a proximal MCL injury, but unfortunately had a distal MCL injury, a distal deep MCL injury. And you can see here in this case, the meniscus is floating. And those patients, in my experience, do not do as well with conservative or delayed treatment, and I'm more aggressive at operating these patients early on. So meniscus going up, I think that's a key, in my experience, for earlier intervention. Now, the patient who has the distal MCL, ACL distal MCL injury that opens up earlier, I think they are at great risk for what we call the Stenner lesion, which I'm sure you refer to for the thumb. And I like to operate on these patients within 7 to 14 days. I like to get immediate post-op range of motion and limited their weight bearing. And these patients, I think, are generally very happy. Here's the typical capsular appearance on arthroscopic. You can see the joint is gaping wide open. You're looking right at the hamstring tendon origin in the back. And in these cases, I believe these patients are better stabilized with some form of capsular repair. So again, as spoken earlier, I'm a big fan of the ligament bridge in this situation. I do believe that these patients, if properly managed, can do very well. Now, if they've got a high degree MCL injury with multi-ligament involvement, the problem with going in early on this patient is arthrofibrosis. And you can see here, this patient had a high degree proximal MCL injury with extension up into the vas medialis. I made the mistake of doing a big surgery early on, and yes, I fixed the ACL and the PCL and everything else. And unfortunately, this patient, despite prophylaxis, developed severe heterotopic ossification. and I spent the next 2.5 years trying to get his motion back. So I would caution on these patients that have high degree of muscular and proximal MCL injuries that these patients should consider delaying on. Now, if it's a lower degree injury, certainly on the lateral side, ACL with a grade 1 or grade 2 MCL, I believe you can treat these patients very similar to the isolated ACL, and I have a tendency to manage timing for surgery based on the clinical appearance of the patient, not the ligament injury. So here's an example, 17-year-old patient, acute soccer injury, had an ACL bony avulsion. I think we talked about bony avulsion repair. And then they had a proximal fibular fracture. In these situations, clearly to me, that's a high-grade injury that does warrant earlier. And most importantly, on their physical exam findings, the patient that has asymmetric hyperextension, I believe that that's a warning sign for us that they have a significant posterolateral corner injury that we should be much more aggressive at. So hyperextension in your early exam. So if they've got a dry sign in this situation, I'm going to fix that lateral side. I'm not going to rely, in this case, an ACL avulsion only. And in this situation, I did an ACL primary repair coupled with a semi-tendinosus augmentation. I know there was some controversy on that in the earlier discussion. Now, the lateral side injury, we in the United States always reconstruct, despite Don Shelbourne back in the late 1980s suggested that many of these patients, if they had a bone avulsion, could undergo just a simple primary repair with either a staple and sutures. And I think nowadays, I think the vast majority of our surgeons are always augmenting, if not reconstructing, lateral side injuries. Now, this is the worst thing that happens to you. Certainly, these are the high-grade multi-ligament injuries where everything's just totally blown apart. I believe in this situation, these patients where they've avulsed the IT band, biceps, have nerve damage, early exploration, early repair, and certainly early reconstruction is what's necessary in this patient group. These patients, unfortunately, do require prolonged touchdown weight bearing in my experience. So our literature would suggest, and certainly I'm sure as yours does too, that early repair and anatomic situations provide the best situation. Now, the problem is the patient that has a varus alignment and a lateral-sided injury. I would say that there's controversy in my experience whether to do a primary realignment procedure with these patients or to consider an isolated primary soft tissue repair. I have not gone to early osteotomy in these patients and have a tendency to treat them with surgical soft tissue repair, hoping to get early repair. Now, in situations it doesn't work, then yes, I'm forced to do a delayed osteotomy approach. Certainly, the posterolateral corner should be reconstructed. We do not rely on isolated repair alone. So their current recommendations, early assessment and making an accurate diagnosis is most important. Splinting and bracing when necessary, but still achieving muscle activation is most critical. And I always do cruciates initially. I think many surgeons will perform soft tissue repairs on the collateral ligaments, and medial and lateral, and do a delayed cruciate reconstruction. I think if you have your A team, as we would say, and you feel comfortable, I try to get everything done in a single procedure and move on early on. So when in doubt, stage the procedures if you think that things are going too long. With that, again, I'll thank you, and we'll move to our next talk.
Thank you very much. Dr. Tonino is welcome to his talk.
Good morning. I think we've heard a lot of talks this morning on ACL reconstruction, and there was an interesting article maybe last year that said that when new orthopedic surgeons in the United States go into practice, there are so many ACL articles they have to be familiar with within the first first 6 years of practice. So I think there's still a lot of things written about ACL surgery. I first would like to welcome you, introduce myself from Chicago. This is what it looks like in Chicago today, so a lot different from Cairo. And I'd like to thank my friend Adele for inviting us here and organizing such a wonderful meeting. A lot of people here today, Adele. Here are my disclosures. So I think as far as ACL surgery, at least in the United States, we still don't know exactly everything to do for ACL surgery and don't know and don't agree on how to reconstruct a torn ACL. So what are our results? This study from 2011 found that for 2 to 6 year follow-up done by very good surgeons, the use of BTB was about the same as hamstring, and they found that the allograft had a higher rate of failure for high school and elite athletes, so younger athletes. At 6 year follow-up, they found that 19% of patients had additional surgery within 6 years of a reconstruction. 12% having an additional ACL surgery, 5% on the same knee, and 6.5% on the other knee. And so we must remember that the risk of ACL rupture in the contralateral knee is very high. And even in this study showed that the risk was very high for the other knee as well. If you do ACL surgery, especially professional athletes in the United States, especially in Chicago, all anybody wants to know is when will that athlete return to play? They say, we'll worry about the arthritis, we'll worry about the risk of re-injury later. When can they come back and play? So what did the Moon study show about return to play? They found that only 70% of high school and college football athletes were able to return to play. And this was shown in studies going back to 1995, even in orthopedic literature in Europe, that only 30% of elite soccer players were playing 3 years after ACL surgery, and none were playing after 7 years. So maybe the doctors who were involved in this Moon study were not very good surgeons. I can tell you they were very good surgeons. But what are the results of our best surgeons, our most high-profile surgeons? The Dr. Andrews study showed in the Journal of Sports Medicine only 63% of NFL athletes returned to play, even though they were using autograft, which is our gold standard for ACL surgery. And this is followed by another study by Dr. Bach in Chicago, who said that 64% of football players returned to play in the NFL. So why is that? And I think the possibilities and some of the things that we've seen today are some of the associated lesions that you see with ACL surgery. It's not just the ACL. There could be some problems with the surgical reconstruction. Maybe the rehab has some problems, and maybe we return them to play too soon. And these associated lesions, which may explain poor results, is there are meniscal tears that happen, there are ligaments that are torn in addition to the ACL, and the bone bruise that we fully don't understand as well what are the long-term implications of the bone bruise that occurs at the time of the ACL injury. We know that ACL injuries can occur very frequently, and if you remove the meniscus, no question you have some effect of AT stability. But what about the repair? Maybe you do the repair, but maybe it doesn't heal, or it heals incompletely. That could have some impact on the ability of that athlete to return to normal use. And if you look at meniscectomy and articular cartilage lesions, they don't create a lot of problems right away at the time of the reconstruction. But if you go further away, like 5 years, 7 years, you can see that the risk of reconstruction and the problem with the reconstruction is very high, so that a lot of them have problems further down the line. What about the associated lesions, the ACL with collateral ligament? The treatment is controversial. We talked about bracing, not bracing. Repair, don't repair. What do we do with partial injuries? What do we do with partial ACL injuries? What is a partial ACL injury? How do we repair it? What kind of rehab do we do? And we know for sure that the return to play is usually prolonged when they have these type of lesions. Among expert surgeons, the technique is very different. We saw a lot of people even here this morning talk about anatomic technique. What is anatomic? How to drill tunnels? What type of graft? Do we use tunnels, sockets? Do we use 1, 2, 3 bundles? What kind of fixation do we do for the ACL? And the graft choice is usually a shared decision because you are the doctor, you know more about the graft than the surgeon, but a lot of times the patient will have some ideas what they want to use as well. And usually the biggest choice that you have to determine is allograft or autograft. Some people talk maybe there are grafts that are sport specific. We should be using a specific kind of graft for different sports. So this is a list, and I think it's dealer's choice as far as what's ligaments, what tendons you use, and what tissue you use for ACL. I know in Asia, Asia, they use peroneus longus for ACL surgery. I don't think we use a lot of it here, but in some countries, the graft they use is much different. And this is an article in the recent journal, I think was within the last month, that showed that the ACL revision rate with hamstring in this study was 2.1% higher with hamstring than it was with BTB. But there are many studies that show no difference, but it makes you think. Among most professional sports athletes, the autograft, BTB, is probably the most common graft we use in the United States. Tunnels, we talked about tunnels. What's better? Transtibial, anteromedial, outside in, aperture is shown to be different, but which is the best tunnels? There's still a lot of disagreement about that. The anteromedial portal has less anterior posterior laxity in the studies, but extension loss during the during the stance phase after the reconstruction. And this study in Journal of Arthroscopy in 2013 found really no difference between anteromedial and transtibial tunnel drilling. Most of us can't even agree where to put the femoral tunnel. They've done CT studies that show, okay, you show me where the tunnel, and they take a CT and they show that point. So the same surgeon usually puts it in the same space. But among very good surgeons, they put it a little bit different area on the same tunnel for the femoral tunnel. So they have different tunnel placements for different very good surgeons. Computer navigation is very popular with arthroplasty, but there's time, cost, and there's been, at this point, no demonstrable benefit with computer navigation for ACL surgery. We went through the double bundle experience, a single and the double bundle, but again, I think most of us have come to the agreement that there's no significant difference with the ACL reconstruction with double bundle or single bundle, although some people still feel quite strongly about that. Sockets are more popular now, but it involves, in some cases, suspensory fixation. How long are the sockets? How much graft do you need in the socket? And for some, because you look at the Chairpersons fibers that happen, they happen at the aperture of the tunnel in the femur. So maybe you don't need so much graft in the bone. Maybe you can use more ligament between the tibial and femoral insertions. Chondro bioactive scaffolds have become popular, and I think there's still a lot of work going on with that, and Dr. Murray popularized this in 2013. We've heard very good talks even recently this morning on a couple minutes ago on anterolateral ligament. There's still a lot of discussion about that. This recent study in the Journal of Sports Medicine showed a demonstrable benefit for using this type of augmentation. But I think all of you should read Dr. Reiter's letter to the editorial in the Journal of Sports Medicine. I think when you read the journal, that's a very important thing to read right at the beginning, and usually highlights one of the articles, and I think it gives you an idea that it's not quite as straightforward about the anterior lateral ligament, and not all the people agree on that. And the biggest thing that I think is the hottest topic right now is the ACL repair. It was mentioned this morning, used for femoral avulsions, but for me, I think, and for other people, there's still a lot of structural questions. What happens to the ligament before it pulls off the bone? What is the character of that ligament? Is it structurally valid or not? How much tension? I heard words this morning, touchy-feely, slightly lax. You know, it's very difficult to know exactly how much tension to put that on when you fix it. And what about synthetic material in the knee? I'm 60, almost 64 years old, so I went through the Gore-Tex phase of ACL reconstruction, and I remember some of the problems with foreign material within the knee joint. And we talked about stress shielding. I know it was mentioned this morning that stress shielding is only for bones, for fracture, but I think it may have some effect on ligaments as well. And the one thing I think about is the slap lesion. The companies came out with anchors for fixing slap repairs, so I have a talk on slap repair. Everybody started doing slap repairs, but they don't always turn out so well. So I think it may be a little bit caution, and as Dr. Bush-Joseph talked, if you have a professional athlete, I don't think you're probably going to do a primary ACL repair. What about the rehabilitation? If it's done poorly, there's prolonged or incomplete recovery, but if it's done well, they return to play too well, and they feel really good, but it's good. What about the biology of the ligamentization of the ACL? Is it too soon? And this has been shown that, in this study at least, that 50% in this study had a overuse injury after return to play after ACL surgery, meaning that the rehab was done maybe not enough, or they returned to play sooner than they should have. And don't forget about the contralateral knee. This recent study again showed a twofold risk of contralateral anterior cruciate ligament injury. So when you do your rehab for your ACL, also important to rehab the other knee as well. And how do we decide about returning? We don't have very good data for that. Only 35% of this, in this meta-analysis, only 35% of studies, only 13% use an objective way of deciding when to return to play. 40% said no method, and 32% said 4 to 6 months, with everything in orthopedic surgery is 4 to 6 months. So what are the conclusions? I think we've seen a lot of significant improvement in our technique for ACL surgery, but I think we're still learning, and it's really fascinating to see some of the new things that we're looking at right now. And I think we're still learning. Even it was interesting to see, even in this meeting, how many times ACL surgery is being discussed in this meeting, including this morning. So I think we're still kind of learning. The reality is that the results of our best surgeons are still not so good. Return to play only 60 to 70%. There's some re-injury and additional surgery as well. Our experts, or so-called experts, are using different methods to reconstruct the ACL. The portals are different, tunnels are different, grafts are different. How we treat associated lesions, what's anatomic, do we do something for the anterolateral ligament, do we do a primary repair, what is our rehab? So we don't have good methods and we really don't have good methods for determining whether an athlete is ready to return to play after ACL surgery. And the one thing sometimes we overlook is whether the athlete feels they're able to go back. So at Loyola we use a subjective test by the athlete too to see if they're psychologically ready to go back to play, and I think that's been shown to be helpful. And I think I'll leave you with a word here. One of my mentors, Dr. Yoakum, who said, every time you think you know everything, you realize you know nothing. And he said, you can repair, but you can never replicate the body athletes are born with. He said, we are good, but the original guy was better. So the one thing I think I will leave you with is don't forget about prevention. And I think we're getting very good at ACL surgery, but trying to prevent that lesion is still something that we should be thinking about. Shukran.
Thank you very much. We take questions now.
Yeah, I'm going to, as a moderator's prerogative, I get the first question. And so, Dr. Abdulaziz, two things. What percentage of your patients undergo a lateral augmentation as a primary surgery? And then number two, why did you make that decision of using a tunnel as opposed to the more cost-effective bone staple?
Yeah. Okay. 50% of my patients, because I deal with young, very active, competitive, whether school level or professional level, and they come young and they come mostly with grade 3 jerk. So the typical indication for adding an extra articulated is. And I used to use staple when I was using the so procedure and proximal to the epicondyle. It used to be lumpy, painful to the patient, and shift it with a screw. But if I go up, I have no objection against using staple.
You know, and I would agree on that because my fear was always if you have distal fixation down closer to the epicondyle, your chance of getting into the ACL tunnel was just too great. So I've always stayed more proximal. I will have to consider the tunnel much higher. Can I just ask the audience as a raise of hands of what percentage of surgeons are using extra-articular augmentation with primary ACL surgery? Okay, so a small percentage. So I think the majority of the audience is a little more tepid on that. So. Other questions?
First with the nerve. In your early intervention was coming to nerve injury. What you are going to do, especially most of these injuries are stiff, not hematomal injuries. The second question is why intervention with the post-lateral corner early, as long as results with reconstruction is better than repair. Why things calm down and then we proceed with reconstruction?
You know, for me, I guess it's maybe a definition of what is early and what is late. I think if you get beyond 3 weeks, your ability to really identify capsular tissue goes away. And so, you know, again, it's a personal bias. I think the literature really doesn't give us much real support in this area about, quote, 7 days, 14 days, 21 days, or 28 days. But for me, it's a matter of ease of dissection. So when I say early, I'm still going to allow the patient to have some settling down of their swelling. I'm going to elevate, have compressive dressings. I do want to get muscle activation. But I think I've got my best chance to really do capsular repair in addition to ligament augmentation within that first 2 to 3 weeks after the injury. And the nerve, I'll give a point on that. And I think the one slide I showed, it was a young woman who fell and had a dislocated knee with a complete nerve injury, albeit stretched. I've had many of those patients, in my experience, that if I decompress the nerve and take any tension away, I eliminate that risk of contracture or scarring of that injured nerve, and I think it gives a better chance of healing. Again, I don't have strong literature support. I'm talking about anecdotal case series. The patients that I've gone and tried to do a lateral-sided injury on at 3, 4, and 5 months out after surgery, I'm merely adding a graft and asking that graft to do everything as opposed to relying on capsular repair. And I think that's the one thing we don't do when we do a delayed reconstruction. Yeah, we may add a collateral ligament or a popliteus tendon graft in place, but we really haven't restored that proper capsular tension. And I think, in my hands, I think the best chance is if you do that within 3 weeks. So I appreciate Dr. Abdulaziz's thoughts.
I totally agree. Actually, I would like to use his own tissues and augment it. Let it heal without tension by the support of the augmentation. You get the person.
Other questions?
Yes. I want to comment about this point about posterolateral corner repair in the acute case. I will show in my lecture in the afternoon about acute posterolateral corner repair. Actually, the repair failure is not for granted. There is a new research that repair could heal, and there's a better result with posterolateral corner repair. The other issue is the hybrid technique, which is repair with augmentation. So I repair the accessory structures, the biceps, the iliotibial band, the posterolateral capsule, and I can augment with the lateral collateral ligament, popliteotubular ligament, and the popliteus. So I do augmentation with repair. So I totally agree that within the first 3 weeks is the golden time for posterolateral corner. As he said, exactly, I have in my experience many patients that I do posterolateral corner reconstruction with repair, and the symptoms of the nerve starts to improve because I remove the tension from the nerve and I stop the stretch of the nerve.
Well, I will agree with Dr. Abid, though, that if you don't get them in that golden period, it's better to wait. And I have seen nerve recovery as long as 12, 15 months after a posterolateral injury. My thought, Dr. Abid, is that I think your best chance is if you can get in there early. And in many situations, I think as Jamie talked about, it's a matter of opportunity because based on how quickly you see the patients or the obstruction for the patient to see you, you may not have that opportunity.
Okay.
Other questions or thoughts?
Yeah, for you again, multi-ligament, knee dislocation, and we are a country without allograft. So what you do first, either envelope first or inside first, and which graft you use?
You know, I obviously being in the United States, we're blessed with the opportunity that in multi-ligament injured patients, I'm using primarily allograft tissues. When I can't, and that's the rare occasion on the true multi-ligament injury, in sports-related multi-ligaments, then those situations I am using autograft tissues. So as I said earlier, like I'm typically using the quadricep tendon for the PCL, and I will use the hamstring tendons for the ACL. And then I will, if I need to augment the medial or lateral collateral, I'm typically using a ligament bridge technique. So I would say that I guess I haven't been frustrated at that point where I did not have allograft tissue available. As a practice, and I'd be interested in Dr. Tonino's thoughts on this, as one, and I've suffered ACL reconstructions on both knees, I would never go into a normal knee. Dr. Peter and Dr. Abdulaziz, is there ever a situation where you would take a graft from the normal knee, the non-injured knee?
It sometimes takes the contralateral proximity to reconstruct the lateral ligament, and or FC-MCL for the FC-CMC for the MCL and the contra for the other side. But in the situation of Dr. Azza just mentioned, you can use the peroneus longus tendon. It's a very strong tendon, and you can three-fold it or four-fold it and use it for the ACL, and use the FC-CMT for lateral or medial ligament, and the quadriceps tendon for the PCL if you have it. And you can cover the whole from one leg.
Yeah, I
Dr.
agree.
Tonino?
Particularly in an athlete, they don't want you doing anything to anything other than the knee that's hurt. So you don't want to mess around with a good knee.
Well, unfortunately, I've had 4 patients that were referred in where they had a contralateral patella tendon autograft as a revision procedure, who subsequently ruptured the patella tendon in the contralateral knee. And those patients are horribly disabled. I guess the other thing that I would again say to our young surgeons, the greater the degree of injury, I think our job at most is to educate that, I think as Dr. Tonino mentioned, we're not making them normal, we're making them better. And the greater the degree of injury, I think the more we have to, the American term we use is couch our expectations with the patients. And I think that early education on what outcomes are going to be makes your life as a surgeon much better. Because there's nothing worse than any of us like is an angry patient.
Actually, patient satisfaction is a compromise between what you can offer and what he can expect. So you have to come to a meeting point.
I'm sorry, can you repeat the question? I'm a believer that I want to do the most difficult thing right away when the situation's optimal. So for me, I'm going to do, if I stage the patient, I will indeed do a posterolateral side repair and augmentation. And then if I'm still fearful that the quality of the tissue is so poor, I'll put them in an external fixator for a couple weeks. I've gotten more aggressive with that, but in most situations, better than 90% of the time, I'm going to go for the first shot. I want to do everything and get out and forget about it. So.
And I'd like to caution also again is, don't feel liberal to take the contralateral graft. CMT, there is a report on harvesting the CMT or hamstring on the contralateral side increases the incidence of the second ACL injury and ACL injury on the other side. There's some reports on increased incidence of ACL injury, I believe.
I would agree with you, Dr. Abdulaziz. Because I got to tell you, I do a lot of elbow surgery in the United States for our overhead throwing athletes, and I take the semitendinosis from their opposite leg all the time and really haven't had a problem. I guess my fear and aversion I've had is from patients who have had a ruptured patella tendon after on a contralateral knee. Those are very disabled patients.
You have a question here?
Well, we'll continue with the multiple ligament reconstruction again. The question related to post-operative rehab. Many of these patients, particularly if you have performed bicruciate reconstruction in addition to one of the collateral ligaments, they become difficult to regain range of movement very quickly, and they remain with the physiotherapy for a long time. I don't know what's your experience with this, and how can you avoid this post-operative stiffness?
At least in my experience, I think you hit it right on the head. Better prevented than treated. And in my experience, a patient with an unstable knee is much happier than a patient with a stiff fibrotic knee and a contracture. So I think one of my early slides was, I have a patient over the age of 55, certainly over the age of 60 with a knee dislocation. I've got to talk myself really hard into reconstructing that patient. And those are the patients I choose non-operatively. And so then beyond that, it's a soft timing. I wish I could say that the magic day or time. For me, the number one element is the ability to initiate muscle contraction in both their hamstrings and their quadriceps. If they cannot fire their quad, you're asking for trouble. Dr. Tonino, your thoughts on that timing?
Yeah, I mean, I think any of us who have done this kind of surgery, I don't do as much of it anymore. It's really complex surgery. So the one thing I would tell the younger doctors who are here, this is not a normal kind of surgery. There are a lot of questions about it, about techniques. I agree with you a little bit. It's easier to identify, quote, normal anatomy if you go in a little bit sooner. So my tendency is to go in a little bit sooner with the patient for that. It's still very difficult to identify the anatomy with this kind of surgery.
I will say this. Watching all the motorbikes around this town, you surgeons have a lot more experience with this than we do. We're driving around town, I'm just going, oh my God, I can't believe that.
Please, in multi-ligament cases, in the last few years, I like to do the ACL and the posterolateral in a stage, because the post-operative rehab mostly the same, but not doing ACL with ACL, because ACL you would like to strengthen the hamstring, while in PCL you would like to strengthen the quadriceps. And lastly, the what's your opinion?
I walk away from, in the acute situation, I am rarely augmenting, usually using a ligament bridge technique. In a chronic situation, I'm always adding a semitendinosus. I will challenge bringing the patient back for a whole other operation and a whole other rehabilitation. So, unless something makes me stop the surgery because of undue swelling, I would not, in this situation, let rehabilitation measures curtail the decision to stage or not stage. That's just my opinion.
Yeah, I agree, especially with the rehab afterwards. You can do closed kinetic chain rehab, which should co-contract both muscles at the same time, reducing the ability to be pulling one way or another.
And actually, reconstructing everything stabilizes the whole knee, because the staging, you might, and when you come back, or is there any reason for delay, you come back with what you have reconstructed is stretched, so they stabilize each other.
Again, my thought is always do the hardest thing first, because you want that under the most optimal situation with the least swelling. Our colleague Rob LaPrade, who's now at the University of Minnesota, who's written extensively in this area, he actually makes an incision and does the lateral side first, then goes and does the cruciates. I'm not sure, my approach is I do the posterior cruciate first, I drill my ACL tunnels and pass the graft but don't fix them, then I open up and do the lateral side, because I really want to be able to do that under tourniquet control. What's your timing approach?
Well, actually, I do the same.
I do the same, thank you.
I opened a can of worms here.
We usually face the patient who has a dislocated knee with a vascular injury. So the vascular repair takes the priority. We need to fix the patient an external fixator, and the vascular surgeon repairs the and in this situation, the vascular surgeon asked to delay any interference for 4 to 6 weeks, and by the time of removal of the external fixator, the knee will be stiff. So do we do arthrolysis first, then do the reconstruction after gaining some range of motion, or should we do reconstruction while doing the arthrolysis, or what kind of approach should we take?
At least in my experience, and I appreciate the other speakers here, what is your goal? When a knee is stiff, your goal is motion. And I got to tell you, a knee that's really stiff is never unstable. So many situations like you described, I can tell at least 60% of the time in my experience, I am doing an arthroscopic lysis of adhesions and never reconstruct those patients. So to me, what is your primary goal? To me, it's like doing a rotator cuff repair on a patient who's got adhesive capsulitis. You know, it's the same thing. I've got a stiff shoulder. I'm going to make it stiffer by doing a rotator cuff repair. So, no. What is your goal of surgery for me? It's get the motion. And yes, if they prove to me they're unstable, then I'll go back and stabilize them.
Yeah, I agree. Even with patients who have ACL surgery and they have a graft that is not isometric, they get very stiff. Sometimes you have to cut the ligament, clean up the tissue, cut the ligament, and let them move. And sometimes they never come back for the ACL reconstruction. So the mobility is the most important thing. And I think that once they get their range of motion, they're very happy. And as far as timing of with the dislocated knee, ACL, PCL, you talk about when patients come back. Sometimes the patients who have these kind of injuries, they don't come back to see you because they're, you know, they're not the ideal patient. They don't follow up with you. So I think we have one chance to do the right surgery for them.
I got the boss up on the stage says that we've got 10 more minutes. So I was getting the cut it from the front row.
Dr. Ahmed Abdulaziz teach us that if you have a knee dislocation, it's better to be reduced, because sometimes we are confronted with a neglected posterior sac, and it came to us that though come help us in just PCL. Then you went in and said you find 3 people cannot reduce this knee to its original position. So first step, you keep the bone to each other and the knee in its normal physiologic anatomical reduction. Then everything can be easy after that.
I agree 100%, and I think Dr. Abdulaziz reaffirmed that. Yes, if at the time of lysis of adhesions, now I've got a grossly unstable knee, you know, whether after an arthroscopic release and then the manipulation, all of a sudden the tibia is floppy and that tibia is going to sublux back posteriorly, then yes, I believe at that time stabilizing or adding a PCL. Other questions? Well, I think I'll give the usual talk that we do at American Orthopedic Sports Medicine Society meetings. Go visit our vendors and thank them and shake their hand, because they're the ones who keep the registration money lower, right?
Thank you very much to the speakers and the audience, and I'd like you to stay on board for a few seconds to show our appreciation to our guests. We'll present some gifts. Okay.
Okay, well, just a great thanks to our ANA representative in the meeting, Professor Robert Hunter. He wasn't here in the opening ceremony, and we wanted to thank you very much to come to the podium to have the award from the EGAA Plate. Thanks for being with us today. Robert Hunter. It's a real pleasure to have the ANA as our friend society coming to this meeting. Please visit the booth of the ANA outside to learn about its activities and how to become a member. And there is a special discount for the Egyptian surgeons to be members. Now, Pietro Tonino, thank you very much for attending our conference. It is a pleasure to have you with us. Well, it is now the end of this session, and we'll convene again in half an hour after the coffee break. Thank you very much.